significant injury or disease. So what I want to emphasize is the restoration of brain function. And so that
The trick there, I mean, the trick, sorry to, but
Mhm,
when and you say you want to emphasize the restoration of brain function,
mhm,
I say trick. The trick is that we're restoring brain function through not standard, but kind of standard physical therapy things like
mhm,
stabilizing your lumbar spine and pelvis through breathing and bracing.
mhm.
That's how we define
Well,
restoration of
that's
brain function,
well,
which
but
we've
that's
taken it another level.
yes, but that stabilization requires an interplay of the physiological systems that exist and the brain. We
Oh, I
cannot
I I
just,
agree, yeah.
yeah. So it's not as if the exercise alone is the starting point. The starting point is the efficiency of the system, the physiological systems and the sensory systems in performing optimally. And then we have a chance to stabilize the spine and move better. So
Well, this
that
I mean, now that you're saying that, this does go hand in hand with our the idea that, first of all, like, how we assess and treat people is truly a neurocentric approach.
Mhm, mhm, mm,
Um, and also that DNS is fundamentally a neurocentric approach to
mhm,
physical therapy. It's not fundamentally a biomechanical approach, an orthopedic
mhm,
approach. It's grounded in the neurology,
mhm,
and
mhm,
you get the biomechanics and the orthopedics out of that grounding
that's right.
neurology. And so you're framing it correctly, which is,
Mm,
we could not all of this stuff that we're doing in the exercise, the breathing is nice, but it's only nice because it is affecting our nervous systems in
mm,
a way that allow efficiency and effectiveness,
mhm. Because
which is
look,
special. That's the
uh,
special thing about it.
yeah, 6 months or 3.5 months or 4.5 months on your back, dying bug movement has been around since I went to school. It's nothing new,
Right.
but so it
Right,
wasn't
yeah.
as if it was invented in 2002 or 1997, but our understanding of where it came from, where the original came from, as a medium for stabilization and activation of phasic and support movement, that didn't exist when people said let's try dying bug. They just were like, we want to keep the spine still and move the legs and load it.
Right,
Did they,
right.
did they know if the ribs were moving well? Not at all. Were we breathing through our abdominal? Not at all. Nobody brought that up.
Were we
We
sucking the belly
yeah,
in,
that's right.
pushing it out?
Yeah,
We had
that's
no idea.
right. We had no idea, and if it hurt, we had no idea what to do about it at all because we had
Do
no
more of it.
concept.
Do more
We,
of it then.
yeah, you either did more of it or you abandoned the whole thing and found something else. So it is really this fact that there's nothing new under the sun, but the interpretation and understanding of what there is
Yes.
deepened over time. It is corroborated, it is researched, it is we collaborate on it, and we come to understand that this phenomena of dying bug exercise has a deep history in natural movement. And if we understand the natural movement, then we command the exercise. We own it in a different manner, and we see where it falls within a sequence of neurologically evolutional movements. Then we have a true understanding of what we can use it for, where it fits in our repertoire. But up till then, dying bug was just dying bug. You did it, and then you went on to do bridges, and then you went on and you did maybe bird dog, and then
Right.
you did there was no logical sequence
Yeah.
in terms of position. There was only logical sequence in terms of loading. You get more weight and more weight and more weight. That was it. Or you peel off the weights until the patient could do it. And the quality was not of a great import. The
Yeah, well,
quantity
I mean,
was.
the quantity was it, but the quality was looking at it now, it's like we didn't have a framework to
No,
accurately describe what quality meant.
that's right.
Quality just meant something else. It
Yes, it
didn't
did.
mean
It
what
was,
quality actually means.
yeah, it was very crude. And we thought quality was, well, it looks kind of smooth and you can do it.
Right, right. It doesn't
Yeah.
hurt.
Yeah. And you're not doing it so slowly that we can't see you moving. So it's kind of good.
Yeah.
But now we have a different aspect. We look at tension around the neck. We look at the degree of activation of the whole canister. We want to know that the patient can continue breathing throughout the movement, that it is fluid, that we don't have pain at the insertion of the rectus femoris. There are guidelines
Hmm.
and pointers that we can now use. And that makes for a much more sophisticated and accurate exercise choice and instruction. So, so again, rehabilitation for me is this discussion with the brain in improving the afferent processing and efferent production of movement and posture. And this is where I think my interests lie in the rehabilitation sequence. And it should, for me, continues up to the basic movements that are covered within the 5-year repertoire. Can you run? Can you jump? Can you stand on one leg? Can you do all these things that are the building blocks for more complex synergies and more complex ADL movements? If I can prepare the patient for those building blocks, then that's the rehab I'm interested in. But the definition is, of course, broader and, as you can see, far reaching because it covers also habilitation, which is children, and rehabilitation, which is the adult retraining aspect.
Yeah. Yeah. I mean, and you described it well. It is more of primary kind of rehabilitation where
Mm-hmm.
we've used the metaphor of like we are building up someone's credit
Mm-hmm.
so good, so
Mm-hmm.
much that it will most likely transfer over into their more functional training or
Mm-hmm.
sports specific training that they're doing because we have rebooted the software so
Mm-hmm.
much and facilitated it so much that it carries over into these other things that they're doing.
And
That I mean
I've
that is
said that training is part of rehabilitation, but rehabilitation is not training.
yeah. Yeah. Yeah.
So
Yeah.
it is more than that.
That's an oldie but a goodie. That's
Yeah, it's more than that. So they are not co equal in status, never have been.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.